Hello and welcome to Say Hi to the Future, Ingenious Thinkers, a podcast aimed at highlighting the human side of ingenuity. My name is Ken Tencer, curator of Say Hi to the Future, helping leaders think differently in the face of uncertainty and ambiguity. Better thinking, better outcomes. Today I'm joined by Professor Jane Speight, one of the world's leading experts on the psychological and social aspects of diabetes. Jane is the Foundation Director of the Australian Centre for Behavioural Research in Diabetes, a partnership between Diabetes Victoria and Deakin University. She is also a leader in ending diabetes stigma and a passionate advocate for putting people, not just numbers, at the center of diabetes care. Jane, welcome to Say Hi to the Future.
Oh, thanks, Ken. Thanks for having me on.
So, Jane, let's start with a simple question, summing up decades into one sentence. If you could sum up in that one sentence what your mission in working on diabetes has been so far and where you think it's going, I think that would be great.
Yeah, I guess my mission over my whole career, if I'd ever really thought about it as a mission as such, would be to improve the health and the quality of life of people living with diabetes. There's so much emphasis on improving health, but not quite so much on quality of life. And yet I see the two as being so interlinked. You can't really have one without the other.
Yeah, and I guess, you focused on diabetes, but I think that that seems to be where we're going. Overall, as a society, is looking to live better for longer and understand what we can do to have healthier lives, better quality of lives, as we age.
Yeah, absolutely. I guess I came to this mission through my early work in diabetes during my PhD, where I was exposed to what it takes to live with type 1 diabetes. And I just saw it as a really relentless, demanding condition. Many of the people that I met at that time had never actually even met another person with type 1 diabetes. So they were living lives that were different to the other people around them at the time. Bear in mind, we're going back 25 years or so now. But they were living, lives that were different because of, the complicated nature of managing a condition like type 1 diabetes. And yet they didn't have that peer support of other people around them who understood what that was like on a day-to-day basis. They had families and friends who were understanding and caring and so on, and health professionals who cared whenever they saw them, but they didn't really have, other people who were really understanding that. And that just actually blew my mind at the time, of just how challenging that was. And when I was working on my PhD, we were developing, an education program, which nowadays we would refer to as a psychoeducation program, because there's a lot of psychology and behavioral aspects to it. Mm-hmm. But at the time, it was referred to as an education program, and it was 5 days. It was intensive, but it was facilitated by nurses and dietitians who didn't stand there at the front of the room telling people what to do. They were facilitating them finding the way forward for themselves. So it was experiential, if you like. It was about learning as you go, and it was learning from the people around you, the other people with diabetes in the room, what they were getting right or what was going on in their lives that helped them to manage this condition. So there's just so much to that, that really kind of drove my interest and I guess passion that stayed with me for the last 25 years. And I think that it's, as you've mentioned, we all want to live long, healthy lives. I mean, ultimately, right. That's what we're here for, is to enjoy life. And if we have, large problems with our health, that obviously detracts from our ability to live life in the way that we want to. So, it's our job, or it's my job to support people with diabetes, but also the health professionals and other people that surround them to provide a supportive environment for that to happen.
And I think, what I find, I mean, it's certainly, I've experienced it through family members. It's a challenge because, okay, so my blood pressure is a little high, which, a lot of people my age might have. I take a pill and my doctor gives me a weight range and I do certain things, but hopefully that never impacts me on a day-to-day basis. Whereas with diabetes, you don't just take a pill in the morning and your day goes great. It's every day to me appears to be a new journey or a new adventure, if you will, and not necessarily in the positive sense.
Oh, that's right. There's just so much there, isn't there? There's taking the medications, if you have medications to take, which can include insulin, other injectables. But there's also thinking about what you're eating and how that might be affecting your glucose levels, and actually monitoring those glucose levels and reacting to them. Do you even understand what those glucose levels are, and how to react to them appropriately, and how to do something about them, even if you have the means to monitor them, and not everyone does. So there's a huge amount of complexity around people having the right tools, the right information and education to make informed decisions about what to do with that information when they've got it, but also how to manage emotions and coping mechanisms for dealing with that on a day-to-day basis. So it's about, having appropriate decision-making, problem-solving, resilience. A lot of resilience is needed for all types of diabetes to cope with those everyday demands.
And as you talk about it, you talk about coping. I mean, You've been drawn into the intersection of psychology and diabetes care, and for me, and you'll correct me or expand as I need to be, but for me, I look at it and it's the psychology of the patient and what they go through, the person with diabetes. It's the psychology of caregivers in their immediate family. It's a psychology of the community at large. And it's also the psychology of the medical profession when you look at type 1 versus type 2. So that's quite an intersection.
It really is. I think you've nailed that. And it is, you're right about that intersection between those things as well. So, the psychology of the health professionals and what's going on for them, and then how that influences how they react to the person sitting in front of them at this particular point in time. So a large part of my work, certainly over the last decade or so, has actually been around the communication of how we talk about diabetes, how we talk about people living with and managing diabetes, because so much of what we can do in diabetes actually boils down to how we talk about it and how that affects people and what they do. So if we think about, diabetes being affected by not just what we do to manage it, but that being affected by what we think about diabetes and what we feel about it, whether that's just the diabetes or the way we manage it or the complications that may or may not arise. That's a lot to unpack just in that whole, thinking and feeling space. Yeah. And thinking and feeling is influenced by the words that we use, because we can't really think without using words, right?
Right.
It's a real catch-22, because where do the words we use influence our thoughts? Do our thoughts influence our words? Where does all of that come from? For health professionals, that comes from the textbooks that they read and the journal articles that they read about the science that's developing and so on. And if those articles and textbooks aren't written in ways that are, not just accurate, but stigma-free, minimizing bias and prejudice, then health professionals come away from those readings with a certain idea about what diabetes is and what people with diabetes are. So it's incredibly important that we get the words and the language right in our communications, so that at the most basic level, health professionals are actually able to speak with people with diabetes in non-judgmental ways that actually make them feel like they're being supported when they come to the healthcare consultation.
And you're talking about the healthcare and professionals. There's both sides in the sense that I've had another gentleman on a few times, and he talks a lot about mental health and the stigma around it. It's a challenge that he's faced. He's also faced another congenital issue, and as he said, as a little boy, I could say I'm a little boy with a bad heart, and people go, "Oh no, that's like." But a little boy who grows up to be a young man and then a man with mental health issues, there's not that acceptance. There's that stigma around, okay, well, you've got a bad heart. We get it. You got to take care of it. We don't see the mental health challenge. Like, we can't put our eyes on it, or we can't touch it, if you will. And the stigma around, as he said, the physical versus the mental or the emotional, it's light years apart.
Yeah, absolutely. And that's the same with diabetes as well, because for most of the time, diabetes is an invisible condition, just like our mental health is. We don't walk around, with a big display of what that's like for us. And it'll only be, certain people that we feel comfortable with really sharing any vulnerabilities that we're experiencing. So absolutely, we need to ensure that it's not just, the young child, that, we can empathize with, it shouldn't happen to a child, or we can empathize with, that poor family. But we also need to be really careful that we're not empathizing in a way that actually makes that person or that child or that family, into the victim in this scenario, because,
right.
When I've spoken with people in these situations, they never want to be seen as victims. And so we can fall very easily into the trap of sympathy being expressed in a way that makes us, we feel sorry for them, they're a victim in this scenario, and so on. But at the other end, like you say, it's really important that, we don't just assume that other people don't have such burdens or baggage around them,
right?
Or that it's their fault or their responsibility that they got that, in a way that we wouldn't say that about someone else. So it's a real challenge, and for me, some people. There's going to be many solutions to stigma, and none of it is easy. But people often latch onto the idea that we just need to educate people, and if they understood more, that they wouldn't stigmatize, that they wouldn't judge, and so on. They wouldn't discriminate. And I do think that that's true. And there's a place for education. We absolutely all need, more education is always a good thing. But I don't think that it's the only solution. And actually, if I think about the reality of people understanding, people outside, the diabetes world who, don't come across diabetes every day, don't understand the intricacies of that. If we expect that the general public is going to have a sophisticated understanding of all that it takes to manage diabetes, I think we're going to be here for a long time. So, because, quite honestly, I don't know a huge amount about a whole load of other health conditions that have a lot of intricacy and complexity to them. So I think, that's a real challenge, to think that we can educate ourselves into a stigma-free world. I think we instead have to approach the idea of this as being about having more compassion, more respect, more curiosity about what's going on for people, and, starting every thought and every conversation with the idea that people are doing the best they can with the resources that they've got. And we just don't know what's going on, behind the scenes for those people, whether that's their mental health, their diabetes, or any number of other things that are going on in their lives.
And when I hear that, it brings up, so I've always been of the mindset, and I'm not saying you don't try and educate people, because there's always room for education. I understand that. But educating 8 billion versus empowering 500 million, and I know I'm conflating different types of diabetes, but 8 billion versus 500 million, just as whether it was my other guest who had mental health issues, or there's a lot of issues that we can have that aren't readily seen, that show up at different times. And we're taught, or we're empowered, we're coached on how to deal with this, how to diffuse. I mean, what is there a balance? Is there a between, between educating and empowerment, between dealing with all these other people in the world who, I'm sorry, but ignorance is a pretty popular thing.
Yeah. Look, I think you raise a good point. Certainly the maths are compelling when you put it like that. But the issue for me around empowerment is that empowerment is always a great thing, I think, first and foremost. So of course we want people with diabetes to feel, empowered to speak up, empowered to live their life as they wish, empowered to challenge other people who, exhibit these prejudices or biases and so on. But I think we are at risk there of putting another layer of responsibility on someone who's already vulnerable, who's already living with complexity in their lives, to have to then take responsibility for being aware that stigma exists and knowing how to handle it and staying resilient to it so that they don't internalize that stigma as self-blame and shame, is actually a big problem. So, if we take the view, well, it's the person with diabetes that really needs to work out how they're going to handle this, then all we're doing is giving them another job to do. And quite frankly, as we've heard, I've heard numerous times, diabetes is a job that no one asks for. They don't get paid for. They don't get a holiday from it. So why on earth would they want another job to do, which is to stay resilient to the stigma that surrounds diabetes?
So let's talk a little bit more about stigma and some of the work that you're doing. The Australian Centre for Behavioural Research in Diabetes recently announced the inaugural Global Summit to End Diabetes Stigma. It's a world first event bringing together advocates, global leaders, and united in bringing an end to diabetes stigma and discrimination. Talk a little bit about this, because I've obviously get your feed. I read about it. It's quite impressive what is happening, what is about to happen. But share with us, how this came about and what you expect or what you hope to happen over time.
Yeah. Okay. So I guess it came about, it goes back a couple of years now. So we've been doing research into diabetes stigma for well over a decade now. Numerous other individuals and organizations around the world are similarly doing great work in this area. But a couple of years ago, some of us came together and thought, well, what's our next project? What are we going to do that's going to have a real impact in bringing an end to diabetes stigma? And we were thinking about it in research terms. But it occurred to us that, another research project probably, it's going to take a few years to get that done and get it published. And it's not really going to be the thing that moves the dial on this issue. So we absolutely need more research. But what we came to was that we actually need there to be a societal shift. And in order for there to be a societal shift, we really need, widespread understanding of what these issues are, how they affect people, what the impacts are, and also what can be done about it. So actually, in the end, 51 of us came together to form an international consensus. We reviewed the literature. We developed brief statements that summarized that evidence and summarized the recommendations that we saw in the literature about what it will take to end diabetes stigma and discrimination. And we, in the end, after a period of, several rounds of Delphi surveys and such like, and a lot of discussions, we came to 49 statements of evidence and recommendations that we achieved consensus on. And those statements of evidence and recommendations form the basis of a pledge to end diabetes stigma. And that pledge is now available. It's been available for a couple of years on the enddiabetesstigma.org website. And very quickly, we had no particular funding or promotion of this. It really was, word of mouth and went viral on social media, if you want to use that term, to 116 countries around the world where someone or an organization has taken the pledge. So we have almost 4,000 individuals or organizations who've taken that pledge now. I don't think those numbers are actually particularly impressive when you consider the, 500 million or so of people living with diabetes around the world. But certainly those organizations represent people or have people with diabetes in them. So there's a lot more involved in those pledges than just those 4,000. But that brings me to, well, what next? And so people were asking us, well, I've taken the pledge, so what next? And there's a bit of complexity in that pledge as well, in terms of how you live that pledge in your everyday life, how you actually do that authentically. And some people are struggling with that because none of these things are necessarily easy. It's taking a different way of thinking about things, and some individuals and organizations, are going really well in some aspects, but they're struggling in others, and others haven't even started thinking about those things yet. So for us as an international group who were working on this international consensus, we started to think about, well, what next from, people taking that pledge? Yes, we can keep promoting the pledge, but what does it really mean? And how do we actually support people to develop those resources now that are needed to make that difference, to shift that dial? And so in order for there to be one day a world where diabetes stigma and discrimination no longer exist, we need to imagine what that's like, and then we need to realize that will only ever happen because individuals, communities, organizations, governments, they all worked together across the multi-levels, across systems, across the whole ecosystem, to ensure that there are equal opportunities for people with diabetes, that there is compassionate care for people with diabetes, that we live in a society where living with diabetes is never a barrier to being respected, to having dignity, to participating fully in professional and social lives, in having and enjoying the best health and well-being that you can. So that's our vision for it, is that all of those people, and you mentioned this, the intersecting layers of community. That's our vision, is that all of those need to come together for this to happen, because ending diabetes stigma can't happen with one person. It can't happen with people with diabetes just being resilient to it. We actually need, numerous organizations and individuals and communities and various stakeholders to come together. So that essentially is why we're having the summit. So the global summit will happen next March, 28th and 29th of March in Jaipur in India. We're anticipating up to 300 delegates attending that summit. And the most crucial thing I think I can say about it is that it's not a conference. it is an action-oriented summit. So people will be coming to that summit to share and to showcase what they're doing in their areas, whatever area they're coming from geographically or in terms of, how they interact with or are involved with diabetes. They're going to come to share and showcase, their latest insights, initiatives, resources, research, strategies, real world successes, examples of what we may or may not think of as best practice, the ongoing challenges and opportunities that they're experiencing with trying to live the pledge in their everyday lives or their everyday professional lives. They're going to be developing or strengthening collaborations and partnerships through meeting those other 300 people in the room. And we're going to be talking about what the indicators of success look like. So how will we know that something has shifted in 2 years, 5 years, 10 years? We'll need to understand how to benchmark that and how to monitor that progress over time. So we're going to talk about the metrics, but we're also going to talk about the storytelling and what are the differences that it would make in people's lives. And ultimately, what are the policy, healthcare and societal changes that are needed? And through that summit and through those 2 days, we're going to unpack as much of that as we can to create a global roadmap of how to go on that journey to end diabetes stigma. So after the summit, we will produce a report that is documenting that roadmap, which will give more people who haven't necessarily been able to come to the summit more insights about what they can be doing to support this initiative.
Well, it sounds wonderful. It sounds like an amazing step forward. And, whether it's ending stigma or bringing about any type of change or transformation, translating, as you said, the research or probably millions of words at this point into a very pragmatic action plan in plain language that the individual on the street can understand or engage. I think that's a phenomenal next step or opportunity. So, where time goes quickly here, I do want to get to this one thing, because again, there's so many layers, who's involved, again, the caregiver and the patient, and then there's, different ethnicities and ages and type 1, type 2, and now more discussion over type 1.5. So there's so many mini targets, if you will. But I still think that from my understanding or experience, one of the biggest challenges you have is, to me, there's this clear medical understanding that type 1 is a disease that patients are born with. And I know some shows up in childhood. I know some is showing up later. But type 2, which is about 90% or so of cases, I believe, of diabetes. You have Diabetes Australia saying that 58% can be delayed or avoided with the right support, or Mayo Clinic going, changing your lifestyle could be a big step toward diabetes prevention. It's never too late to start. It's a tough one when it comes to ending stigma in that type of conversation, because I get to the 8 billion. I don't know if you can get 8 billion people to first understand diabetes and second understand the nuance between type 1 and type 2, let alone, type 1.5. And for somebody like me who has it, it's been in the family, but again, there's been some habits, if you will, that definitely drove that type 2. Boy, if some of the pundits are going, 58% can be prevented, cut down, aided of type 2, of course, that's a heck of a wave to talk against or around.
Yeah, it's a really challenging space, but science is evolving all the time, and you quite rightly pointed out that we now understand more about different subclassifications of diabetes, of all types of diabetes. Mm-hmm. So particularly type 1 and type 2 have several subclassifications now. And, there's research just being presented just a few weeks ago at the European conference around the early detection of type 1 diabetes, and there being various stages of type 1 diabetes. Now, a few years ago, people would have said that type 1 diabetes is a condition that comes on suddenly. There's no warning signs. You can't prevent it. And now we're talking about there being early detection. There are warning signs, and potentially there will be things that people can do to prevent it. And that they won't necessarily be the same things that people can do to reduce their risk of type 2 diabetes. They are different conditions and they have different risk factors. But that's just an example of how the science is evolving, and how we need to appreciate that what we thought we knew isn't necessarily what is now currently the accepted knowledge. So in type 2 diabetes, we had some remarkable trials of 25 years ago that were looking at the prevention of type 2 diabetes. And there were several landmark trials around the world that gave us those statistics that you just mentioned. About 58% of people may be able to prevent or reduce their risk of type 2 diabetes or delay its onset. But the problem is that, everyone gets very excited about that kind of evidence, and diabetes organizations and the media and health professionals all latch on to the idea that this can be prevented. But what we have to remember is that those trials were well funded. The people who came into those trials were highly select in groups. We start out with selection criteria for people to come into trials, and we go from thousands of potential participants down to, a few hundred eligible participants. So already we've knocked out a whole load of people who potentially this approach isn't suitable for. And in those trials, we find that the interventions that are offered are intensive. The support provided is intensive. So health professionals have not only provided people with medications and with dietary approaches and physical activity approaches, but they've also provided them with intensive coaching. And when those trials are translated into real world programs, although a lot of the right elements of those mechanisms or those key components, ingredients, if you like, are in those real world programs, they're rarely done with the intensity that they were in the trial, because that's not how we live in our everyday lives. And we add on to that the environments that we live in that are pretty unhealthy. If you think about the amount of advertising and availability of unhealthy foods and so on, and the way we live our lives in terms of sedentary behavior, commuting time, time at a desk or, sitting down. There's all sorts of, issues around how complex it is for people to reduce those even those modifiable risk factors. Okay. And if we add that onto the fact that what we now know is that you have to have a genetic predisposition to type 2 diabetes in order to get it. If it was true that it was only about what we might refer to as lifestyle, then what we would see is that there's more like, 60 to 70% of people walking around with type 2 diabetes, but that's just not the case. So, the fact that we have, in some parts of the world, 60 or 70% of people living with overweight or obesity, but we don't have the same proportions of people living with type 2 diabetes shows that there's a bit of a disconnect in that thinking around this all being about the way people live their lives. So, and I'd say that, I'm now going to be very careful to say I'm not suggesting that obesity or overweight is all about how people live their lives either. A lot of the same issues are true for that. So I guess, what I'm trying to get to is, the science is important. We now also have studies that talk about the remission of type 2 diabetes and how that can be achieved. But I would say that all these studies are demonstrating to us is the mechanisms by which it can happen, and that it's powerful when it can happen, but it's possible. It's not reality for everyone. So I think it's something that some people can take inspiration from. They can feel that there's things that they can do. And I think that's always a really important thing, that people feel that they have some personal control, some agency over their own fate, and that there are things that they can do that are within their control to manage their risk factors or to reduce their risk factors. But the idea that type 2 is just this thing that you brought on yourself through being lazy or, whatever else, is just, in my opinion, not true. It's unfair. It's harmful, and it's doing a lot of damage, and we need to change that narrative as a society.
Shane, that's a very strong and powerful message, I think, to end on today. And it's also one of the reasons that is, the research part of me always says to people, quant is very good at providing me some headlines or some indicators. The qualitative, the story, as you've just told it, is to me where the real power is in these situations. So I've been in conversation today with Jane Speight. Jane is the foundation director of the Australian Centre for Behavioural Research in Diabetes, a partnership between Diabetes Victoria and Deakin University. Jane, I just thank you once again for coming on and having this conversation for our community.
Thanks so much, Ken. I've really enjoyed our conversation, and I really appreciate the opportunity.
If you enjoyed this episode and you want to support our show, leave us a review and join our mailing list by visiting www.spyder.works. That's SPYDER.works, and subscribe to our channel. Leave us a comment with who we should interview next. Thank you for listening, and see you all next Friday.